Okay, hello. Today we're going to begin talking about psychopathology, mental illness. We're going to continue with, I think, topics that you probably thought psychology was more about before you entered this course. And now we're finally getting to that aspect of psychology with which many people have at least some name familiarity. Um, in the public consciousness, that is clinical psychology. We began in some previous narrations talking about a personality. Now we're moving into again an individual differences area that has much to do with differences between people. So let's begin by talking first about mental illness in general, and then we'll talk about anxiety disorders. And then in a subsequent narration, we'll talk about other disorders having to, that are probably in many ways more severe, such as schizophrenia and those kinds of disorders. Okay, so psychological disorders are really patterns of thoughts, feelings, or actions that are deviant, distressful, and dysfunctional. The three Ds, if you will. If we look at this definition, we'll look at it in a couple of slides. When we think of disorder, we're referring to a state of mental or behavioral ill health. Nowadays, we use the term disorder much more than we use the term mental illness to convey, because of the connotations that illness has that probably are not are less appropriate than the whole idea of a disorder. Really, we're talking about patterns. So, referring to a collection of symptoms that tend to go together, and not just seeing a single symptom. Many of us have singular or even a couple of symptoms of any number of disorders, but alone they don't constitute the disorder. So, for example, one of the symptoms in the pattern of brain cancer is a headache. Okay, but many other things obviously go along with it. So just because you have a headache, we all get headaches. Most of us don't have brain cancer. So for there to be distress and dysfunction, the symptoms must be sufficiently severe to interfere with our functioning, one's daily life and well-being. Okay, we will see this again, this theme later. That many of us involve, many of us feel occasional distress and depression and things like that, but they don't necessarily interfere with our daily functioning and well-being. And the term deviant simply means differing from the norm, differing from the average, the typical, the characteristic, the normative. So according to the APA, and in this case we're talking about the American Psychiatric Association, there's also the American Psychological Association, which I think we've referred to in the past. According to the APA, behavior meets the criteria for a disorder if the behavior causes distress or dysfunction in daily activities, and the problem is caused by something within the person. Okay, it could be due to biology, it could be due to learned behavior, it could be to faulty thinking in one's processing of information. Okay. Also, it must not be a normal response to an external event. Okay, so it's something that happens within the person, not some characteristic response that we might all have to some, extreme external event. Okay, so for example, feeling sad after a loved one's death is not a disorder. Okay. The problem is not, and also the third set of criteria to be a psychological disorder is that the problem is not an intentional reaction to some societal problem or policy. So the person isn't acting out in some intentional kind of way because of something that's happened out there in the world. So what do we mean by deviant, okay, or abnormal, okay? So abnormal is not just behavior that differs from normative behavior. So we saw the term deviant literally means, not, different from the norm, as does the term abnormal, okay? But people who win the Pulitzer Prize, NBA players, all of these, in both cases, the members of these groups deviate dramatically from the norm, but they're not disordered. They deviate from the norm. NBA players are usually way above average in height and have an extraordinary and often uncanny level of talent. Pulitzer Prize winners are outstanding journalists who are way above average and outside the norm, right? Okay. So it's not just differing from normative behavior. That's not when we say abnormal in a psychological sense, we're not just talking about behavior that differs from the norm, okay? And what is normative differs among cultures, okay? So what would be considered normal in one culture, as you might expect, would not be considered such in a different culture, necessarily. Abnormal and normal behavior, they fall on a continuum, okay? And so it often becomes a question. So, for example, later we'll be talking about dissociative disorders, where there's this separation of consciousness, of some aspects of consciousness from other parts of one's mental well-being and thinking. Okay, we've seen dissociation in a number of cases, particularly when we were talking about memory and consciousness. We talk about dissociated kinds of behaviors where at one level you're focused and selectively attending to something and doing something, and there are things going on in your behavior and in your head that you're not really at the moment consciously aware of. We've got a normal level of dissociation, okay? We see dissociation in psychological disorders, okay? Much more extreme dissociation. So at the extreme, there are what are called dissociative disorders, formerly known as multiple personalities, where a person alternates between different aspects of the self, maybe full personalities with names and everything, that are rather thoroughly dissociated from another aspect of personality, and they move in and out of consciousness to become the dominant feature in one's thinking. We'll talk about that later, but the point here is, sometimes it's difficult to distinguish where on this continuum of dissociation, dissociated thinking, does something become a disorder. Okay, we can see the extremes, and to what extent does one get close to the extreme before it's really a disorder? When is it a deviant or a psychological problem? And that's something that needs to be determined case by case. So when we talk about abnormal, putting it all together, something is abnormal to the extent that it's deviant, right? Maladaptive, okay, so it interferes with daily functioning, okay? It doesn't serve the person well. It gets the person into trouble and creates all kinds of problems. It's maladaptive. And also it must be distressing to the person, okay? It's something that the person would, that troubles the individual, okay? So all these qualities are necessary before we call in psychology something to be abnormal psychology or abnormal behavior. And abnormal behavior typically is behavior that in some sense threatens the safety or well-being of others. Now, modern psychology, which we've seen throughout the course, has numerous perspectives on abnormal behavior. So if we look at abnormal behavior as we've defined it in the previous slide, we can talk about all these perspectives. The cognitive perspective would be that, well, abnormal behavior involves really bad thinking habits, faulty thinking, misinterpretation of what's going on around one. Okay, we move to the psychoanalytic, the psychodynamic, which we've seen previously in discussing personality, that it's associated with unconscious, unresolved conflict. Humanistic, remember that approach, block personal growth. The evolutionary perspective, an exaggerated form of something that, from an evolutionary and genetic point of view, was adaptive. So, for example, it's normal to have for human beings, and it was something that evolved in us to have a fear of snakes, for example, okay, or a fear of heights, okay. Both of those are normal, and then we can understand how that natural selection might have wired us for that. Some extreme kinds of phobias are exaggerated forms of what is normally an adaptive reaction that we've evolved to have. Okay, but for some people, it gets very exaggerated and very dysfunctional for them. So we'll talk about phobias a little bit later. Behavioral. So if you're a behaviorist, you'd be thinking about inappropriate conditioning or modeling. Socioculture, problems reflect cultural values and beliefs. And of course, the biological aspect is there's problems with brain function, a genetic predisposition, biochemistry can be involved. So all these perspectives have something to say and have a take on abnormal behavior. Depending on the malady, depending on the form of psychopathology, a different approach or a different perspective might be more or less relevant. So initially, when we moved into the late 19th and into the 20th century, the model of abnormal behavior was a medical or biological model, okay, where that basically, think of a medical perspective, that physical disease is at the basis of abnormal thoughts, feelings, and behavior. So we have a kind of a medical perspective on that. Okay, so this is where psychiatry grew out of. That the causes of abnormal behavior are genetic, abnormal brain structures. There can be neurotransmitter or hormonal imbalances. That these are the this is where the root of abnormal behaviors lies, okay, among these kind of biological causes. So the focus is on abnormal behavior as being an illness or a disease rather than on the whole idea of health, okay. Defining what's mentally healthy, the whole idea is that, well, mental disorders have to do with our diseases, they're illnesses. And diagnosis involves determining which illness is present. And so one treats the symptoms to produce a cure, okay? Just as one would with a physical ailment or a physical illness. And one thinks in terms of prognosis. What's the probable course that this illness is going to take with and without treatment? So there's long been critics of the medical model of abnormal behavior. So some critics, such as Thomas Szasz, have argued that mental illness is really something that's socially constructed. It really depends on how society construes what is normal, okay, and how society is structured to basically tolerate and encourage and reward what it considers to be mentally healthy behavior. Okay, so it's a social construction. Okay. Other critics more generally complain that environmental and psychological factors are underappreciated by this model. Now, it's clear, okay, one thing that is clear and consistent with the medical model is that brain chemistry is involved, okay, and that drugs can help with symptoms, if not necessarily with the core causes, okay. So clearly there is some significance and relevance and importance and centrality of a medical perspective, okay. But nowadays, it's only considered one part of the puzzle of abnormal behavior. Psychological models of abnormal behavior flip us around, and we saw some of those in the multiple perspective slide a couple of slides ago. The idea here is that abnormal behavior is caused by past and current life experiences, illness, okay, war, so we end up with post-traumatic stress kinds of syndromes, abuse, social rejection, failure, all these nasty aspects of life experiences can be contributors or causes of abnormal behavior. And no one psychological model basically dominates exclusively. We saw that in the previous slide, looking at a couple of slides ago, look at the various perspectives, but we know the psychoanalysis perspective, which was really the first kind of psychological model of abnormal behavior. And it's interesting that it came out of someone who initially from Freud, who really was trained initially in the medical model. Okay, he of course was a physician. So childhood experiences, unconscious conflicts, defense mechanisms to deal with anxiety. Here's where we should be looking at the causes of abnormal behavior, according to that perspective. The behaviorist and the cognitive social learning perspective, the abnormal behavior is learned. It's affected by our expectations. Remember Bandura and the whole idea of social learning and expectancies and observational learning of role models, that these are also primary causes of abnormal behavior. And then there's a humanistic perspective, the blocked potential for personal growth that we saw. So that's a little reiteration of a previous slide. Social cultural model, the cultural context determines. So basically culture affects the types of stressors to which we are exposed. Okay. Think in turn, compare the kinds of stressors we experience in America as opposed to what one might experience in a culture in Africa, for example, or in the Far East, more collectivist kinds of cultures. The stressors are going to differ. Culture will determine the types of disorders we have, and the types of treatment that we receive. Okay, different cultures really have different models and different definitions of what's abnormal, and they also have different ways of dealing with abnormal as their culture defines it. The prevalence of disorders clearly differs across cultures. So, for example, in the United States, troubled teenagers are very likely to act out. Okay, they might become bullies. Okay, They act out in they might become class clowns. Okay, um, a lot of acting out. Okay, if you look at, for example, the culture of Thailand, in that culture, much less likely to see that kind of acting out among troubled teenagers than you are to see withdrawal, okay, sulking, lots of sleep disorders associated with teenagers in Far Eastern, Southeast Asian culture than in the United States. So it depends on uh, the culture you're in. Okay, some abnormal behavior syndromes, if you will, are truly culture bound. Okay, so for example, eating disorders are only found in Western cultures. Okay, you don't see bulimia, you don't see anorexia nervosa, you don't see these eating disorders outside the United States and Western Europe, and in particular in the United States. Whoa, sorry about that, guys. um, an interesting example of a culture-bound syndrome is a disorder uh, well known in Asia. Okay, called Coro. Okay, this is a disorder which we might think very bizarre in the West, but think of some of our disorders. Um, This is a disorder in which Asian men refuse to leave their house because they fear that their penis and testicles will be absorbed by their bodies. So it's kind of like a version of agoraphobia, which is the fear of the marketplace, the fear of leaving home that some people in the United States, mainly women, experience. So getting out there, okay, is anxiety provoking in some ways, and this is how it manifests itself in this particular culture, but it's not something you'd see elsewhere in other parts of the world. So there's a social cultural context in which we have to consider abnormal behavior. So diagnosis of mental illness. All right. So that's the process of grouping mental disorders based on those patterns of behavior that we saw very early as a one of the defining qualities of a disorder, that there's a pattern. Okay, um, the American Psychiatric Association publishes the DSM. It's now in its fifth edition. The DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, which provides a list of mental disorders, and within those lists lists the behaviors that are related to the prominent symptoms. So again, it lists the pattern, it lists the symptoms that go along with this mental disorder. Okay, it lists the prevalence rate for men and women. Okay, it indicates the typical age of onset. It describes the predisposing factors. Okay, so this is the manual that one refers to when one is trying to diagnose a person who's presenting with a series of with some psychological difficulties. And there's concerns with this. There always have been. Okay, because even with objective criteria, diagnoses using DSM-4, well, actually 5, got to fix that, are not highly reliable. DSM-5 just came out in 2015, and to much fanfare and criticism and all kinds of jockeying around in terms of the pharmaceutical companies and the medications that would be available. It was a very complex and controversial undertaking, as it always is. Okay, but diagnoses with the DSM, not really that reliable. Okay, different therapists take the same information from patients and consult DSM and come up with different diagnoses. It's not uncommon. The revised version is better than the past. It's got checklists of observable behaviors that help to guide diagnoses, and usually, there's a whole list of symptoms defined in terms of the behaviors. Okay, and if you've got to have a certain number of them. Okay, need to be checked off as characterizing the client before the client is diagnosed with that disorder. Clinical judgments, even guided by the DSM-5, can be influenced by stereotypes about gender, race, and age. Okay, so one example that I like to give is a study done a number of years ago where basically descriptions of a disorder known as histrionic, okay, hysterical kind of personality, if you will, okay, versus antisocial personality disorder were sent to clinicians, okay, with the gender varied. Okay, so so these can present quite similarly, okay, but so, and these were actual people who had been so diagnosed, okay, and now histrionic at that time, it was called histrionic hysterical personality, was gender linked in the sense that it tends to be more associated with women than with men, whereas antisocial personality disorder, the classic psychopath, okay, tends to be more associated with men. Okay, so they're gender related. Okay, now the diagnoses made based on these descriptions tended to be very gender consistent. Okay, so basically there was misdiagnosis more often of men as antisocial. Okay, they tended to be more readily, the same description was described as antisocial, okay, whereas the person was more readily described as histrionic if they knew that the client, the patient, was a woman, okay. Then there's the whole idea of labels, okay, and this is best seen, probably most dramatically seen in a classic study that David Rosenhan did back in the 1970s. It was a study in which Rosenhan and some of his students actually reported to a mental health facility, okay, a psychiatric hospital, of which back in those days there were many more than there are now. They were much more populated. There's been this whole idea of deinstitutionalization that has taken hold in the last 30 or 40 years. So they went to a psychiatric hospital and to intake, and basically complaining that they were hearing voices, okay, and then acted pretty normally, okay, just with this whole, and both he and his students were very successful with just this one kind of presentation on hearing voices, okay, and got them admitted, okay, got them a diagnosis, okay, of having a psychological problem, often schizophrenia, okay. Then when they got into the the institution, they acted completely normally, okay, but their behaviors became increasingly interpreted. Remember, selective interpretation, selective attention, where the label that they had been given affected how the nurses and even the psychiatrist and the staff basically reacted to them and interpreted their behavior. So it became difficult to actually get out of there because all their very normal behaviors they did is as inpatients was interpreted as consistent with their abnormal um, um, diagnosis. Okay, often as schizophrenic, undifferentiated schizophrenic, or whatever it might have been. Okay, so Rosenhan gives one example of many. Um, so he basically went off by himself and sat in a chair near the corner and started writing down some things in a notebook. Okay, and the nurse basically reported to the psychiatric nurse reported to the psychiatrist that, well, this particular patient seems to be engaging in a lot of note-taking behavior, suggesting that he's really paranoid. But all it was doing was writing things down on a piece of paper. So the label can affect how one is viewed. Okay, so if you're stuck with the label of having a psychological disorder, your behavior is going to get interpreted is likely to get interpreted in a fashion consistent with that. Okay, so as Rosen demonstrated, when sane people presented hearing voices, their subsequent normal behaviors were viewed as signs of pathology. Actually, he wrote a classic essay on this experience called "On Being Sane and Insane on Being Sane in Insane Places." David Rosenhan. You ought to check that out. You'll be amused, I guess. Okay, let's talk a little bit about some disorders. So in our continuation of this narration, we're going to start with anxiety disorders. So an anxiety disorder basically involves having an overwhelming set of feelings of anxiety, okay, apprehension, fear, and that's accompanied by autonomic nervous system arousal. Remember the autonomic nervous system, when we're experiencing stress or in times of emergency, the ANS kicks in and all the symptoms of stress and anxiety show up not only behaviorally but in all of our systems, right? Okay, our autonomic nervous system takes hold. Anxiety disorders are by far the most common psychological disorder. And and they're more common in women. Okay, in fact, women are twice as likely to report anxiety disorders as are men. Okay, now one has to look at that statistic. You can look at that statistic in a number of ways. It's probably inflated because men are less likely to be willing to report that they're having psychological problems, right? It's not in traditional terms, it's really not a manly thing to do, right? So men might underreport their anxiety. Okay, they're supposed to be strong. They're supposed to be in charge. To have anxiety would be a sign of not being so strong. Okay, so women may be more likely, just simply more likely to report their anxiety than men. But nevertheless, the data suggests that women are more likely to have anxiety disorders. Now, nearly all of us experience periods of anxiety, but remember, it's only a mental disorder if its chronic intensity disrupts your life. Remember that it has to be this disruption. Okay, it's distressing to you. Okay, and it disrupts your life. Okay, it's maladaptive. Remember that term. Okay, from earlier on today. Okay, so we all have anxiety, okay, at various points, of course. So there is a set of anxiety disorders, okay. So there's generalized anxiety disorder, there's panic disorder, there's phobias, there's obsessive compulsive disorder, there's post-traumatic stress disorder, PSD. Okay. I think this might be from a different edition of Myers, and I don't think it was the module, so ignore, it's discussed in whatever module we're dealing with with anxiety disorders, and not quote unquote chapter 3. Okay. Okay. So an example of a generalized anxiety. Well, actually, let's go through these one by one. Okay, and you can come back to this if you want to, especially when I post the slides. But you can look this over as a summary. But I want to get to the subsequent slides which get into the more specifics of this. Okay, but I will say here are a couple of 3 specific kinds of phobias that are among the most common. Agoraphobia. This is the fear of going out in public, fear of going to a mall, fairground, or remote beaches. Basically, people get specific fears of the term literally means fear of the marketplace. Okay, so it's really a fear of leaving one's home and going to, and in particular, certain kinds of places that have a lot of people involved. Okay, specific phobias, fear of spiders, fear of elevators, fear of heights. And then there are social phobias. Okay, in fact, one of the most common phobia. Okay, and pretty much everybody may be characterized by this to some extent, but for some people it gets downright debilitating. The fear of public speaking. Okay, major kind of phobia. But let's move along with some of these anxiety disorders. So generalized anxiety disorder. Okay, so this is when there's non-specific, free-floating anxiety, not linked to a specific sort. There's nothing specifically that happened, but the individual gets this this anxiety just comes out of nowhere. It's free-floating. It just comes on. Okay, and there's arousal. There's all kinds of anxiety kinds of symptoms that occur. Okay, people that have generalized anxiety disorder tend to be hypersensitive to criticism. They constantly worry. Okay, so it's a generalized kind of thing. Okay, so anything, it can come on in a free floating way, but it can be triggered because it's free floating by criticism. Okay, by even the smallest kind of matter that a person will obsessively worry about. And it's very much, when you do have an anxiety attack, and you have a generalized anxiety disorder, you get shortness of breath, you get stomach ailments. Okay, people might have bowel issues. And some of these symptoms, okay, are, because it's an underlying free-floating thing, are kind of there on a chronic basis. Okay, people have stomach problems, indigestion, diarrhea. They're a mess. Okay, and that's a generalized, but it's a constant kind of generalized malady. Okay, not just something that happens a couple of times a year. Okay. Panic disorder. Okay, so so this is in one sense it's like a generalized anxiety disorder, but one can have because generalized anxiety disorders, one often has a panic attack that really brings it on, but usually it's there on a constant sort of basis. Panic disorder comes out of nowhere without warning. You have this overwhelming anxiety just comes upon you. Okay, you get chest pains, you hyperventilate, you get heart palpitations. Panic disorders can lead to fear of leaving home, because when they happen, they'll happen when one is in like a public place or out doing something. So then there becomes an association of being outside the home and having this kind of anxiety attack, this panic disorder. Okay, it becomes a conditioned response. Um, is there evidence for biological origins? Well, it starts without provocation. So, remember, occurring without warning. That would suggest that we're not. It's not being triggered necessarily by the environment. Okay, so that would be consistent with there's a biological thing primarily going on. Okay, um, panic attacks. People who are having panic disorders are submitted to research. Uh, when they have panic attacks, one can measure changes in the prefrontal cortex. And panic disorder is quite responsive to drug therapy. Okay, drugs do keep it, can do a good job keeping it under wraps, if you will. Okay, so these are evidence for biological origins. What about psychological origins? Okay, well, the initial panic attack often can be traced back to some kind of trauma. Okay, something set it off. It might have been a number of things, but so there's a psychological root to it. Okay, but it's become generalized and non-specific to anything that can be readily seen. They just have a panic attack, again, without warning. And panic disorders do respond to cognitive behavioral therapy, which combines relaxation training, something we're going to talk about when we start talking about therapy, talk about systematic desensitization. Okay. Then there's phobic disorders. Okay. People who have specific phobias, persistent irrational fear of an object or a situation that in reality poses no threat. Okay. There's no real need to be fearful. Okay. Of the object or of the situation that one has this phobia about. Okay. And so when one develops a phobia, it's one of the reasons it's difficult to undo it, if you will. Okay, is because one has developed a phobia toward what should be considered a relatively harmless situation, but the person doesn't come around enough to find out that it is really harmless because they learn to avoid the situation. So if you don't encounter the situation and ultimately learn that it's not associated with something dangerous, okay, or to be fearful of, okay, you're never going to get over the phobia, okay. Social phobia is a fear of social situations in which one might be evaluated. Okay. Now, a lot of people have social phobias to a greater or lesser extent. So for some people, it's debilitating. Okay. These are people who have extreme shyness to a fault, literally to a fault, that it really interferes with their life. Okay. And you add the caveat in which one might be evaluated. Well, for people who have social phobias, okay, any situation you fear you're being evaluated, okay, you're meeting a new person, okay, you're in some kind of social situation, you feel like your personality, your worthiness is being judged. So it's not just in situations where you really are being evaluated, it's in situations where you think you might be evaluated, which, if you have a social phobia, is basically every situation. So phobias can result from classical conditioning and from observational learning. Now, we appear to, as I pointed out earlier, okay, with the evolutionary perspective, we're genetically predisposed to acquire simple phobias to particular stimuli. For example, snakes. Another one that I mentioned was heights. Okay, So we're kind of, as a species, we're kind of, human beings are kind of oriented, predisposed to form phobias towards certain objects owing to our evolutionary heritage, okay? For some people, the gene, if you will, is very strong, and they acquire these phobias, straightforward phobias to these stimuli, um, to a large degree. Okay, so that they become true phobias for the person. Okay. Um, yeah. Obsessive compulsive disorder. Okay, so OCD. It's a catchword nowadays. Hey, it's guy's really OCD, obsessive compulsive disorder. Okay, so you notice the hyphenation, obsessive compulsive. So obsessive refers to obsessions. Okay, getting intrusive, unwanted thoughts, usually about very negative things and dangers and things like that. Okay. Um, and so people might become have on thoughts about dirt and germs. The clean freaks, people that like constantly washing their hands. Okay, uh, uh, people might have unwanted. That's well, the obsession is to be thinking about. It's not the behavior. It's the oh, there's all this dirt, there's all these germs. Okay, they're everywhere. I can't see them, but I know they're there. Okay, aggression. Some people have like, these intrusive thoughts about, uh, uh, that they're going to commit some aggressive act, or some aggressive act is going to be committed on them, or they think about horrifying things that could happen to them. They can't get, or to someone else. They can't get it out of their mind. It's very intrusive. They're obsessed with it. Um, some people have like this obsessive need for symmetry, for order. Then neat. They have thoughts about when things are out of order. They have all these intrusive, unwanted thoughts that they worry about that. Okay, and then the compulsions are the urge to engage in behaviors, ritualized behaviors, in response to these thoughts. Okay, so you've heard of people who are constantly washing their hands, are constantly like doing things to clean themselves and rid themselves of germs, that they have this compulsion to do it. Okay, uh, we know about the Felix. Remember the Odd Couple? The Felixes among us who have this great need for sympathy. I'm sorry, for symmetry and for order. Okay, so they're real neat freaks. Okay, they had this compulsion to be constantly straightening things up and keeping things neat, and so on. Okay, um, some people have obsessive compulsive disorder, OCD, with regard to certain kinds of ritualized behaviors. Um, so they take 40 minutes to before they can go to bed, because they have to do everything in a ritualized order. They have to check the locks on the doors 4 or 5 times. They have to make sure that this is done and that is done. They're constantly checking. They have to, they have to make sure that they, that they, in some extreme cases, move their bowels before they go to bed, or else they won't be able to sleep. That they run into these ritualized kinds of obsessive compulsions that they engage in. Okay, but even more generally, obsessive compulsives, just basically, um, you know, sort of obsess over just about everything. They have unwanted thoughts and that intrude, and they're always trying to. They're anxious about it, and they're, um, um, you know, unable to function in a relaxed kind of way. So among the compulsions, we've seen them checking things constantly, washing, counting, hoarding, uh, extreme example of OCD manifestation is people who like hoard everything, and in some extreme cases you see people living in houses that are filled with several years worth of newspapers piled up, or hoarding string and building it into balls, and just can't throw anything away, so that they end up with tons and tons, completely full house where they can't even move around much, because it's filled with basically, just junk that the person can't throw anything away and hoards things. Okay, that's an OCD manifestation. Um, Now, why does such now obviously this is dysfunctional. The person who's living in a house where they can't even move because they've hoarded so much, or the person who you know, uh, can't stop washing their hands, or spends 40 minutes just checking everything in the house before going to bed, and including their own personal hygiene, as well as the stove, the locks on the door, and on and on. This is not something that people are necessarily well, I won't even say necessarily. This isn't something that people are enjoying. Okay, um, but they persist because they are reinforcing, in one way, they reduce the anxiety. Okay, the anxiety that's evident in these obsessive kinds of thoughts. Okay, those thoughts create the anxiety. The compulsions distract or satisfy, or shall we say, the um, um, the uh, the issues associated with those unwanted thoughts. Okay, so the anxiety gets reduced. So the compulsion persists because it's reinforced. Okay, by the reduction of anxiety. Okay, it's negative reinforcement, right? It's taking away something bad. Okay, the anxiety. Okay, and the behavior that produced that will be repeated, and it's the compulsive behavior. Origins, psychological. Well, we do know that if, and it's one form of behavioral therapy, repeated prevention of enacting the compulsion during an obsession can reduce compulsive behavior. So it's a process of extinction. So if the person is not um, allowed to act out when they get an obsessive thought with the compulsion, okay, uh, eventually the compulsive behavior gets extinguished, okay, because its absence is not, followed by uh, anything bad, okay. So biological origins. Well, it turns out that OCD is responsive to various kinds of drugs, SSRI, selective serotonin reuptake inhibitors, um, uh, which we've seen very early in the course. We were talking about neurotransmitters. Okay, so this is a way of getting more of an excitatory kind of serotonin in the synapses. Okay, and not really clear why, but there is a response, okay, such that people who are treated this way basically show less OCD, okay. Um, so where do anxiety disorders come from? What's the etiology? Well, we've already talked a little bit about it. We talked about um, how it's reinforcing, but that means it's already been created. Okay, you already have the OCD, you already have an anxiety disorder, or what have you. Um, so one can talk about, at the biological level, the root causes, a genetic predisposition, um, neurotransmitters, okay, having a deficit in something like serotonin, which we also know helps reduce depression. It seems to have a way of reducing the negative thought processes that are associated with depression, okay, and so also those negative thought processes associated with OCD, okay, um, because it basically gives more oomph to the system, if you will. Okay, allows for more active kinds of proactive kinds of thinking and interpretation um, and things like that. So there's the biological roots, okay, and then there are psychological roots, okay, psychological causes, okay. Well, we know classical conditioning, right? Okay, and phobias. So phobias can get started. Um, that we might have a genetic predisposition, but one can, if one has an anxiety kind of reaction, okay, uh, to a stimulus, okay, um, that that usually produces a normal response, or if some trauma was associated with that stimulus, okay, we learn, you know, we learn that stimulus might, in fact, particularly if it's associated with some sort of trauma or some sort of even kind of association in one's mind. Okay, one can be the anxiety response can be a classically conditioned response. So it was formerly a neutral stimulus, or one that we were kind of geared toward having anxiety toward. Uh, Genetically, such as snakes and heights and so on, okay, uh, enclosed spaces um, and such, um, could become a classically conditioned response, this anxiety response. Remember how classical conditioning is tied in really well with emotions, okay? That was John B. Watson's point, okay? So it can be involved in phobias, and it can be involved in very kind of specific anxieties. Sometimes people develop um, anxieties toward very specific kinds of objects, which we wouldn't normally think should produce a phobic kind of response, okay, or an anxiety response. Well, it could be because of the pairing of that stimulus, okay, with something that some unconditioned stimulus that prompted the response, some traumatic event, some kind of experience that connected that stimulus. The stimulus, the specific stimulus becomes again a conditioned stimulus, a CS. Okay, so a lot of the thinking is that anxiety disorders are very much a product in many cases of classical conditioning, helped along by whatever biology might be uh, facilitative of developing that response to begin with. Okay, so classical conditioning often is one of the prime players as a cause of a phobia, as a cause of a specific anxiety. Operant conditioning then kicks in as be very much involved in the maintenance of those responses. Okay, um, so what clinical psychologists and psychiatrists traditionally called the neurotic paradox comes into play here. Neurosis is a term that isn't used too much anymore, but it really dealt with. It was a term that was sort of a catch-all term for neurotic behavior. And nowadays we talk about them in terms of anxiety disorders more so than neurosis. Okay, but the neurotic paradox idea was how the heck does this very dysfunctional, maladaptive, distressing to the person behavior continue even though it creates all this havoc in the person's life, okay? the anxiety, okay, the the obsessive behaviors, okay, the avoidance, okay, all this distressing kinds of stuff, okay. How does it get maintained? Because people aren't enjoying this, okay. Well, that's the neurotic paradox, okay. The behavior continues despite the fact that it is dysfunctional and distressing to the person, okay. Well, the idea, of course, the major idea with operant conditioning is that the behaviors that are enacted to deal with the anxiety, the obsessive behavior, okay, whatever one does um, um, to deal with the anxiety, okay, of this dysfunctional behaviors that deal with it and in some cases keep the anxiety going. So, for example, avoiding situations that have been associated with anxiety. So we're reinforced. The behaviors, anxiety kinds of behaviors, neurotic kinds of behaviors are reinforced because they reduce the anxiety. Okay, and the reduction of the anxiety is a negative reinforcer that maintains the anxiety-related behavior. Then there's this whole idea of secondary gain. Okay, another way in which operant conditioning kicks in to maintain anxiety, the responses to anxiety and the anxiety itself, is that people get sympathy from loved ones, sympathy from friends. They get special kinds of treatments in some ways. Okay, so there is some secondary gain in acting out one's anxiety and maintain and continue to be anxious because one it tends to be socially reinforced. So the primary gain is the reduction of anxiety brought on by uh, the uh, brought on the reduction of anxiety that the anxiety responses produce. Okay, and the secondary gain is the reinforcement of the support and social kinds of reinforcers that one gets by being um, overly anxious, having an anxiety disorder, and so on. Okay, so so it's a one-two punch. Classical conditioning produces it, um, and operant produces these anxiety responses, be they obsessive behaviors or avoidance responses, um, and classical condition, because they reduce the anxiety caused by the classical conditioning, and operant conditioning kicks in to maintain it by reducing through anxiety reduction and social support. Cognitive theories basically talk about how what happens is one learns to interpret stimuli that should be seen as neutral as threatening. Okay, and so um, so once you've kind of made this interpretation, okay, and you've identified a situation or stimuli or certain environments, okay, as threatening in some way, okay, they produce anxiety, okay, then the interpretation is going to be increasingly selective. You're not going to put yourself in situations where you find out that it's not, it shouldn't produce anxiety. You do put your, and the situations that you do put yourself in, that you do find yourself in, are going to be interpreted in ways that, um, promote the anxiety. So you got to break into, and we'll see this with psychotherapy. Cognitive therapists want to break into that faulty thinking and interpretation. Okay, and one thing that tells us that there's a psychological stuff going on is that the stress often, that some sort of stress, be it trauma, be it some kind of ongoing kind of like um, stress in one's life, often is a precursor to developing some form of anxiety disorder, okay? Particularly generalized anxiety disorders. Okay, um, but even panic attacks and phobias, okay, can kind of be manifested after a person has experienced a prolonged amount of stress. Okay, so anxiety disorders causes come at you from lots of directions. And here is a little summary. Okay, um, psychological, faulty cognitions, maladaptive learning. We talked about biological, uh, and then there's the cultural pressures that one faces. Okay, may lead to a lot of stress, and then it gets translated into some development of a certain kind of anxiety based on wherever a person's vulnerabilities might be. Okay, so that pretty much concludes um, this narration where we talked about what do we mean by psychological disorders, and looking at the first major category, the most common category of of psychological disorders, namely anxiety disorders. Okay. Next, we're going to talk about mood and personality disorders. Okay. Um, and this is where the old distinction, no longer really used, but in psychology or psychiatry, but nevertheless, well, some people use it. Um, the distinction between neurosis and psychosis. Okay, so once upon a time, um, disorder is the most broad distinction between the various kinds of psychological disorders that people can have, or between those that are neurotic and those that are psychotic. Okay, and the neurotic side of it basically was what nowadays we really call anxiety. Okay, the anxiety disorders. Okay, so the person who's was neurotic. Okay, the defining characteristic of someone who's got is someone who's got a lot of anxiety. We saw the various forms. Okay, and but still in the realm of reality and managing it somehow, plodding on, suffering. Okay, but in touch with reality and trying to manage and live through this this disorder, this anxiety disorder that the person has. Okay, but when one moves into a psychotic state, okay, so the psychosis was thought to be this is when people kind of lose touch with reality. Okay, um, when people, so we get to the very serious disorders such as bipolar disorder, schizophrenia, um, and and dissociative disorders. That's when that's what we're going to be talking about next, and they fall under this traditional category. So it's a good breaking point here, and still remains a nice way to transition from anxiety disorders to mood and personality disorders. We're also going to talk about, um, you know, personality disorders don't necessarily involve a loss of touch with reality, but the mood and the dissociative kinds of disorders indeed do. So that's what we're going to get to next. Okay, so that's it with anxiety. Okay, uh, and uh, and hopefully everybody can relax now because this narration's over, and there'll be another one soon.